Good morning, all. I am here to talk about the outcomes of intrascleral fixation of single piece IOL rather than multi-piece IOL. To start with, there are various known causes of aphakia for which the various treatment modalities include spectacle correction, contact lens, or IOL implant. That can be anterior chamber IOL, iris fixated IOL, or scleral fixated IOL. So there arises a question: with availability of such a vast variety of options, what is the need of this study? Here I tell you that aphakic spectacles can cause roving ring scotoma and Jack-in-box phenomena, so it is really very cumbersome to wear them continuously. Now coming to the ocular physics, when eyeball move, kinetic energy is acquired by eye muscles which get dissipated into the internal fluid. Here crystalline lens acts as a barrier and provides a stabilizing effect. So in absence of crystalline lens, placing the IOL closer to the center of rotation decrease these centrifugal forces and thereby stabilizing the eye and minimize the complications like iritis, CME or RD. This stabilizing effect gets clearly disturbed in cases of aphakia or when the IOL is placed in anterior chamber. So in absence of a posterior capsular support, sulcus fixation is the best possible option and that can be done through scleral fixation. Now uh, how to fix IOL to the sclera? That can be done through suture, but again it is associated with the risk of complicated suturing technique and the suture break. Another technique is the use of fibrin glue to fix the haptic to the sclera, but glue is quite expensive and carries the risk of viral transmission. So, intrascleral tucking of the haptic came, and all the previous techniques and procedure advocated the use of multi-piece IOL for this study. We evaluated the use of single piece IOL because technically when intrascleral fixation is done and outward force is applied on the haptics to fix them into the scleral pocket. This force can cause haptic break intraoperatively, which indirectly increases the economic burden and disturbs surgeon mental peace. So we evaluated the results of single piece IOL in terms of visual outcome, complications and post-op centration. In this observational study, we have a detailed evaluation including the OCT and the pentacam. Now coming to surgical technique, after infusion of cannula, there was sclerotomies at 2 mm behind the limbus and the scleral tunnel is made parallel to the limbus. IOL was implanted, haptics were exteriorized and tucked into the scleral tunnels. So we evaluated 50 patients. Major diagnosis was of surgical aphakia and follow-up was done for 6 months. We can see here the change in BCVA was found to be significant in our study, while the change in IOP and corneal astigmatism was insignificant, showing that the scleral tunnel did not affect the corneal astigmatism. On day 1, BCVA was insignificant because of the fibrin reaction and raised IOP due to maneuvering, which was managed medically, and after that the BCVA started improving. There were few cases of complications also intraoperatively and postoperatively, which all were managed medically and surgically. So at the end, we have well-centered IOL as seen on slit lamp and pentacam. Sulcus fixation of single piece IOL is not very popular because thick haptics can cause iris irritation, and also the haptics are planar rather than angulated, so they do not vault the optic posteriorly, resulting in complications like iris transillumination defect, secondary glaucoma and pigment dispersion. Our lens has an offset design and also the greater part of haptic is externalized. So neither the haptic nor the optic came in direct contact with the iris, thereby minimizing the complications. Also the haptic of single piece IOL are sturdy in nature, which allow easy externalization, and a thick haptic block the sclerotomies completely, providing better stability and long-term centration. So in conclusion, I can say that after 6-month follow-up, we found our technique of sutureless, glueless, intrascleral fixation of single piece IOL safe and innovative. Here is a small video of our technique. Video. Yeah, yeah. So after making the sclerotomy, scleral tunnel was made. Then this is a sclerotomy. Single piece IOL was taken and implanted, and the haptics were grasped and externalized and tucked into the scleral tunnel. I'm really sorry for the poor video quality, but we are in process to upgrade our recording system. Thank you.
Thank you very much. Don't you think the haptic will be very thick?
And
The sclerotomy has to be very
It
big.
easy to tuck into the tunnel.
It will be
Because
difficult to
it's
tuck
thick
also
and
in the
pliable.
tunnel.
It's not like proline is rigid, it goes in easily. So this will be difficult to tuck
Yeah,
into.
sir, that was difficult technically, but the results were
Better.
all
Is it hydrophilic or hydrophobic lens?
Sir, initially we used hydrophilic biotech lens. After that we used hydrophobic. So we have better results with hydrophilic lens because
Hydrophilic
yes,
lens.
sir, because their
Stretch.
haptics are
Can be
slightly
stretched,
flexible
yeah.
and better stretchability.
Okay.
Hydro. Okay.
How many cases did you do?
50.
50 cases.
50. Okay, thank you.
Mark this.
Yeah. We have to announce the winner also, right?
Or they will announce. You will announce? Take it. Yeah. You take it. Okay, they take it. Okay.
We are supposed to announce that side. We are supposed to announce the result right here.
I don't think so, sir. Because the semi-finals.
Toasting करा रहे हैं. With that, we come to the end of this session. I think the next chairpersons are waiting for the next session. Thank you all very much for your patient hearing and for the good presentation. And thanks to all the co-panelists.
And congratulations to all the presenters. You have
Everybody
taken real
presented very
efforts
well.
and it was very good and quite good.
Everybody
good
is a winner
papers.
actually. I think the difference must be one odd mark here and there.
Yeah, and keep it up. Yeah, it's a good work.